Good morning, students. Today we'll be discussing about the diseases of nerves. The most common word you will come across in the disorders of nerves is neuralgias. The word neuralgia actually derived from a Greek word, and neuralgia is the pain in the distribution of a nerve or nerves. There are different types of facial and cervical neuralgias. Atypical facial pain, geniculate neuralgia, glossopharyngeal neuralgia, migrainous neuralgia, occipital neuralgia, paratrigeminal neuralgia, postherpetic neuralgia, sphenopalatine neuralgia, and trigeminal neuralgia. Let's talk about trigeminal neuralgia. It is also called as tic doulorex or trifacial neuralgia or Fothergill's disease. I think all of you know the anatomy of trigeminal nerve. It has got three divisions. First branch is upper or ophthalmic branch. Second division is middle or maxillary branch. Third division is lower or mandibular branch. It has also got a ganglion called Gasserion ganglion. Trigeminal neuralgia is an archetype of orofacial neuralgias which follows the anatomic distribution of fifth cranial nerve, that's the trigeminal nerve. It is limited to one or more branches of trigeminal nerve, mainly affects second and third divisions of trigeminal nerve, that is maxillary and mandibular divisions of trigeminal nerve. This neuralgia always exhibits a trigger zone, that means a particular zone which triggers pain, and stimulation of this zone will initiate paroxysm of pain, that is sudden onset of pain. And this pain is accompanied by a brief spasm called tic. And the trigeminal neuralgia has got the highest suicidal rate of any disease. Coming to the etiology of trigeminal neuralgia, the first etiology remains idiopathic, that is the cause unknown. Also due to pathosis along the course of the nerve or any brainstem tumor or infarction. Also due to circulatory insufficiency to Gasserian ganglion or trigeminal nerve. Also multiple sclerosis, that is a condition where demyelination of nerves occurs. When you see the clinical features, this is more commonly seen in an age group above 40 years. Women are more commonly affected. Right side of the face is affected more. Maxillary and mandibular division of trigeminal nerve are affected compared to ophthalmic division. It has got extremely severe pain which is unilateral in nature. How will you describe the pain in trigeminal neuralgia? In the early stages of trigeminal neuralgia, patient will experience a dull ache or burning sensation or a pain resembling a sharp toothache. This stage is called pre-trigeminal neuralgia. In the later stages of trigeminal neuralgia, pain can be described as lancinating or piercing type, searing or very intense, stabbing or sudden sharp pain, or like an electric shock and lightning bolt. This pain is initiated when the patient touches a trigger zone on the face. Patient often experiences a painful jerk. That is, the patient suffers from spasmodic contraction of facial muscles. Hence, the term tic doulorex is used for trigeminal neuralgia. And the attack lasts for few seconds to few minutes, and there should be a refractory period. That means the patient is free of symptoms between the attacks. And it is also associated with excess lacrimation, conjunctival injection, and intense headache. Let's see the trigger zones in trigeminal neuralgia. They are nasolabial fold, cheek, vermilion border, midfacial area, and periorbital region. And the triggering factors could be a mild touch, breeze, a gentle movement, eating, or smiling. Finally, the patient learns to avoid touching the skin over the trigger area and frequently goes unshaven or unwashed to avoid any possible triggering of an attack. There are certain specific criteria for the diagnosis of trigeminal neuralgia. First criteria is that it should be of abrupt onset. That means even a light touch to a triggering point should initiate the neuralgic pain. Next criteria is it should be of severe paroxysmal lancinating type of pain. Duration is of less than 2 minutes and there should be a refractory period and it should last for several minutes between two attacks. Also, the pain is limited to one or more branches of trigeminal nerve with no effect on the motor component. Pain should diminishes on taking carbamazepine medication and also there should be spontaneous remission of pain. Histopathologically, we couldn't find any unique features for this particular disease. And the features we could find are fibrosis in trigger points, myelin degeneration in Gasserin ganglion or nerve, amorphous plaque in the ganglion. Next comes the most important part, that is the differential diagnosis. Of course, the first differential diagnosis we can consider is the dental pain. It can be removed by intraoral examination and proper history taking. Second differential diagnosis is migraine neuralgia, where the neuralgic pain persists for hours, but in case of trigeminal neuralgia, the pain lasts for only few seconds to few minutes. Sinusitis is also taken into consideration, but the trigger zones may be different. Another differential diagnosis we can consider is Costin syndrome. Tinnitus, otalgia, and dizziness is present in Costin syndrome, whereas it is not found in trigeminal neuralgia. Also, trigeminal neuritis or trigeminal neuropathy can consider as a differential diagnosis, but the condition exhibits pulling or pressure sensation which lasts for hours or days or weeks. Next, coming to the treatment part, topically we can use capsaicin cream. It's a substance P suppressor. Anticonvulsant medications can be used like phenytoin, carbamazepine, and gabapentin. Surgical management also done with removal of bony irregularities if any, peripheral neurectomy, injection of alcohol and boiling water, surgical sectioning of trigeminal sensory root, and microvascular decompression. These are the surgical management of trigeminal neuralgia. Next type of neuralgia is Sphenopalatine neuralgia. Initially, Sphenopalatine neuralgia was attributed to nasal ganglion, but later it was found that it also involved the Vedian nerve, that is a nerve passing through pterygoid canal, hence the name Vedian nerve neuralgia. It is also called as Horton syndrome or alarm clock headache or cluster headache. It's an idiopathic syndrome consisting of recurrent brief attack of sudden severe unilateral pain in the orbital, supraorbital and temporal region. It may be accompanied by other autonomic symptoms like watering of eyes, swelling around eyes and nasal congestion. Coming to the etiology, actually, the etiology is not understood completely, but some factors are suggested. They are hypothalamic hormonal influences, immune factors, vasoregulatory factors, hypoxia, hypocapnia, so decreased carbon dioxide concentration, and genetic factors. Clinically, we could see unilateral paroxysm of intense pain in the region of eyes, maxilla, ear, mastoid, base of the nose, and beneath the zygoma. Sometimes this pain will extend to the occipital area, and paroxysm of pain have a rapid onset which persists for about 15 minutes to several hours and then disappears rapidly. It may be precipitated by emotional strain or injudicious intake of alcohol. There are no any trigger zones for this particular neuralgia, and the attacks develop regularly, at least once a day over a prolonged period of time. And this onset of paroxysmal pain occur exactly in the same time of the day and hence referred as alarm clock headache. After few weeks or months, this trauma disappears completely and this period of freedom persists for months or even for years. Other findings associated with pain are sneezing, swelling of nasal mucosa, severe nasal discharge, epiphora or watering of eyes and bloodshot eyes, paresthesia of skin of lower half of face. Men are more commonly affected. Initial attack is in the age group of less than 40 years. Cocainization of sphenopalatine ganglion means anesthetize the ganglion with cocaine or alcohol injection of the sphenopalatine ganglion. Resection of ganglion also can be done. Surgical corrections of septal defects also done if needed. Another most important type of neuralgia is glossopharyngeal neuralgia. Glossopharyngeal neuralgia is the ninth cranial nerve neuralgia. It is rarely associated with trigeminal neuralgia. Etiology also not known. Ischemia may be suggested. Clinically, it is seen in an age group of 15 to 85 years. There are no any sex predilection for this particular neuralgia. Pain is of unilateral in nature, but rarely it can be bilateral also. Paroxysmal type of pain seen in the infraauricular area, tonsil, base of the tongue, nasopharynx, posterior mandible and lateral wall of the pharynx. Pain can be described as an episodic pain which is sharp, lancinating, extremely intense, abrupt onset and of short duration which lasts for 30 to 60 seconds. Actually, definite trigger zone is difficult to identify in this glossopharyngeal neuralgia, but posterior oropharynx or tonsillar fossa is considered to be a trigger zone. Triggering factors are talking, chewing, swallowing, yawning, touching tonsil with blunt instruments. Coming to the differential diagnosis, since the pain is related to jaw movement and the patient points the neck below the angle of the mandible as the greatest pain area, one can confuse this with TMJ dysfunction syndrome. Treatment done by topical anesthetic agent, carbamazepine and phenytoin, surgical by resection of glossopharyngeal nerve intracranially or extracranially.